Hi there! Today we're going to be talking about hormone replacement therapy. Before we delve into it, I just want to give you a disclaimer. I want to give people all of the information that I can and then help them to make an informed decision. I'm not really for hormone replacement therapy or against it. We just base it on what is the best thing for each patient at that point in their lives. One of the things people often ask me is, am I even a candidate for hormone replacement therapy? And so there are certain conditions where we say, really not a good idea for you. Those are in people with a history of breast cancer or other estrogen-mediated cancers. If you have a history of blood clots or pulmonary embolism, which is a blood clot that goes to the lungs, heart disease, strokes, and liver disease. Also, if you have a history of unexplained vaginal bleeding, I've mentioned before this is something we never ignore, but you certainly wouldn't want to start hormone replacement therapy until it is fully evaluated and that anything serious is ruled out. As it stands currently, only 3 to 4% of perimenopausal or menopausal women seek treatment for their symptoms. So why is that? Well, in the early 2000s, there was a big, huge clinical trial called the Women's Health Initiative. This happened when I was in my residency, so just after the Earth's crust cooled. And it showed these really increased risks of blood clot, strokes, breast cancer, and other adverse effects. So suddenly we went from a society of everybody needs to be on hormone replacement to, wow, nobody should be on hormone replacement. Well, we have an intervening 20 years of data, and so we know that in certain circumstances they can be very beneficial and safe depending on your risk factors. So I'm not going to bore you with all the details of clinical trials, but after scrutinizing the results for 20 some odd years, what the general consensus is nowadays is that the vast majority of those who had adverse outcomes in the Women's Health Initiative were over age 60. These are not the same women that come to their doctor looking for help for menopause. These are usually women in their late 40s or early 50s, in those early menopausal years. And the benefits appear to outweigh the risks in those women, especially if we limit their hormone replacement therapy to about 5 years. Most women, that is enough time on these medicines to get them through that transition to where they can adjust to the new normal. Prior to the early 2000s, when I was in medical school, everybody used estrogen for everything. We thought that it prevented coronary artery disease, aka heart disease, dementia, among other things. Well, now we know that it really should be used just for menopausal symptoms because the research doesn't support using it for prevention of other diseases. Now, this is, of course, a discussion that you are going to be having with your doctor. So I'm not going to tell you which medicine to take. Hopefully, I can just give you that helpful information. Number one rule in hormone replacement: if you have a uterus, you cannot take estrogen by itself, because estrogen by itself leads to a much greater risk of endometrial or uterine cancer. We've discussed that before, and that's the reason why we never, ever ignore postmenopausal vaginal bleeding. But number one rule, if you have a uterus, you're going to be on combination therapy. The big trick here is that the combination estrogen and progesterone medicines are the ones that seem to have the increased risk of blood clots, heart attacks, strokes, etc. So we try to keep people on the lowest dose possible. How do we achieve that? One of the nice things is if you use a gel or a patch or something that is transdermal, meaning absorbing through the skin rather than taking pills, you can use a dose that is about 1/10 of what it is if you're taking the oral medicines. Some women also prefer hormone pellets, and this is again that individualized approach that you will make to the decision. When I say there is a quote-unquote increased risk, that equals about 2.5 to 3.5 people per 1,000 patients who would be on hormone replacement therapy for 5 years or greater, which is why we sort of use that 5-year cutoff and then reassess whether you still need the medicines so you can decide what's best for you. So for the duration, while you're on your hormone replacement therapy, if you and your doctor decide that's the right approach, you want to make sure that you keep up with your breast cancer screening, your colorectal cancer screening, check your cholesterol levels and your blood pressure, make sure everything else is under control. Risks are absolutely increased in women who are smokers, so that is, in some people's minds, an absolute contraindication or a reason why we wouldn't prescribe hormone therapy. So keep that in mind before you have this talk with your doctor too. Hopefully now you are armed with some helpful information to help you make an informed decision and make it through these transitional years a little more comfortably. Don't forget to like and subscribe.